Okay, excuse me. Hello, everyone. Thank you for joining us this afternoon or this morning, depending on where you are. I'm Don Metz, Health Affairs Executive Editor, and I want to welcome you to today's media briefing featuring authors from the Office of the Actuary at the Centers for Medicare and Medicaid Services, who will present the latest national health expenditure projections through the year 2032. We're publishing this article today, June 12, as an ahead of print article with an embargo time of 4 p.m. Eastern. I'm going to repeat that information several times, so please bear with me. Again, news stories should not appear before the 4 p.m. embargo time. I want to say that we're really proud to play a role in bringing you this important work, and very proud of our long-standing relationship with the Office of the Actuary. At CMS, we've been publishing historical health spending data annually from that office since our inception in 1981, and we've been publishing the spending projections since 1991. And so really proud, again, very important work. Data from the Office of the Actuary, I think, as you know, represents the gold standard in health spending data. And really also want to commend the team of economists, statisticians, and actuaries in that office who compile and analyze these data on an annual basis in order to provide the policy community with very important information. So thank you for all that work. We're pleased to be able to offer you an advanced copy of the study today, but again, please do observe the embargo time, 4 p.m. Eastern today. Before I introduce the speakers, I want to turn it over briefly to Sue Ducat, our Senior Director of Communications, who has a few things to say. Sue?
Thank you, Don, and thank you, everyone. If you want an advanced copy of the study, please contact me by email at sducat@projecthope.org. That's sducat@projecthope.org. I will put that in the chat as well. Thank you. Back to you, Don.
Thank you, Sue. Now, let me introduce today's presenters. They are all from the Office of the Actuary at the Centers for Medicare and Medicaid Services. Jacqueline Fiore is an economist there in the National Health Statistics Group. Her work on spending forecasts focuses on Medicare and select healthcare sectors. She also studies innovative payment reform models and the economic impact of new treatments for chronic diseases. Andrew Madison is an actuary in the Medicare and Medicaid Cost Estimates Group. His work on spending forecasts focuses on spending by sponsor. He also studies Medicare fee-for-service payment system trends, bundled payment methodologies, and various Medicare-related policy proposals. They will present today. John Poisel is also here and will be available for questions. He is Deputy Director of the National Health Statistics Group, where he directs the work of CMS's National Health Expenditure Accounts Projections Team, whose work again is being presented here today. In addition, John oversees a variety of research efforts related to healthcare pricing, utilization, and spending. And there are also a number of other folks from CMS here today. We want to welcome them and welcome all of you again. So now let me turn it over to Jacqueline and Andrew to begin the presentation. We will, on the conclusion, we will of course have questions and answers. So Jacqueline and Andrew, on to you.
Thank you for the introduction, Don. I appreciate that a lot. Just getting my computer organized, and thank you for navigating the slides for our study. Okay. I want to acknowledge Andrew Madison, who's my co-lead on this effort, John Poisel, the Director of the National Health Expenditure Accounts Projection Team, and the significant contribution each member of our team made for this effort. I will be presenting on our major findings, enrollment, and payers, and after that, Mr. Madison will present on sponsor, sector, and the Inflation Reduction Act. Next slide, please. Background and methods. This is an annual publication that includes 10-year projections for the entire health sector. The projections are constructed by a 9-person team that uses both actuarial and econometric modeling techniques. The Medicare projections are consistent with the 2024 Medicare Trustees Report. These numbers generally reflect current law, as well as an assumption that the public health emergency ended in 2023. The article will be published in Health Affairs today, and as Don mentioned, the embargo will lift at 4 p.m. Next slide. Major findings. During the full projection period, years 2023 through 32, growth in national health expenditures is projected to average 5.6%, and outpaced the nominal GDP growth rate of 4.3%. Non-price growth, particularly utilization, is driving the projected trend in 2023. Consequently, by the end of the 10-year period, we project an increase in the health spending share of GDP from 17.3% in 2022 to 19.7% in 2032. In 2023, national health expenditures are projected to have grown 7.5%, which is faster than the nominal GDP growth rate of 6.1%. Contributing to this higher rate of growth was an increase in the use of care associated with the insured share of the population, which is expected to have reached an unprecedented high of 93.1% in 2023. This is largely related to Medicaid enrollment, which is expected to have hit a projection period peak of 91.2 million in 2023 on an average monthly enrollment basis, as well as gains in direct purchase enrollment of 8.3 million over 2023 through 25. The 8.3 million in direct purchase plans is largely marketplace enrollment, but also includes non-marketplace direct purchase plans, as well as Medigap policies. Over the 2024 through 26 period, enrollment shifts occur, and by 2032, the insured share of the population is expected to fall 90 to 90.7%. A few notable declines in enrollment contribute to the insured share of the population falling. First, Medicaid enrollment is projected to decline to 81.0 million in 2024, and slightly further to 79.4 million by 2025, following the expiration of the continuous enrollment requirement. Second, direct purchase enrollment is expected to decline by 7.3 million in 2026, or 19.2%, due to the expiration of the IRA's temporary extension of enhanced subsidies and associated temporary special enrollment period. We incorporate provisions from the IRA on our estimates for retail prescription drug spending, which is the only standalone drug category in the projections, whereas drugs administered in health settings are categorized as spending in those settings, for example, hospital or physician and clinical services. The IRA is expected to put upward and downward pressure on two of the major payers. For Medicare, earlier in the projection period, the following provisions are expected to put upward pressure on retail prescription drug spending: the elimination of Part D's 5% coinsurance for catastrophic coverage, the $2,000 cap on out-of-pocket spending on Part D, and rebates that shift from the program to the point of sale when drug negotiations begin. As we move further in the projection period, downward pressure on Medicare is expected from manufacturer discounts for the low-income population, drug price negotiations, and a linking of price increases to the consumer price index. In addition, out-of-pocket retail prescription drug spending is projected to have lower spending growth because of the more generous Medicare Part D benefits, reflecting the elimination of the 5% coinsurance for catastrophic coverage in 2024, the implementation of the $2,000 cap on out-of-pocket spending on Part D drugs in 2025, and the applicability of drug price negotiations beginning in 2026. Finally, during 2027 through 32, personal healthcare price inflation and growth in the use of healthcare services and goods contribute to projected health spending that grows at a faster rate than the rest of the economy. Next slide. Wow, that was a lot of information to digest, and we broke my rule of not having too much text on the slide. So now we're going to stick to some graphs. These graphs will be reviewing some of those major points for us. In this slide, the black solid line marks national health spending growth. The green long dashed line denotes nominal GDP growth, and the blue short dashed line is the share of GDP devoted to health. Over the 2023 through 32 projection period, that is to the right of the vertical line, average national health expenditure growth of 5.6% is projected to outpace that of average nominal GDP growth of 4.3%. Underlying this differential are faster growth in personal healthcare prices relative to economy-wide price growth, the continued aging of the population, and increasingly more demand for healthcare relative to income growth. To better understand healthcare price growth, I want to clarify that it is primarily driven by the lagged impact of recent inflationary pressures on the prices for inputs that are required to furnish healthcare, in particular labor. Taken together, these factors contribute to an increase in the health spending share of GDP from 17.3% in 2022 to 19.7% in 2032. As we will discuss on the upcoming slides, changes in enrollment growth for Medicaid, private health insurance, and Medicare, in addition to provisions of the IRA, influence national health expenditures growth throughout the projection period. Next slide. This graph illustrates the expected annual average enrollment growth rates for the three major payers, Medicare, Medicaid, and private health insurance in the blue bars on the graph. The black solid line shows the insured share of the population. The takeaway message from this graph is that the insured share of the population does not plummet as pandemic-related policies impacting enrollment expire. Specifically, in 2023, gains in enrollment for Medicaid during the continuous enrollment requirement and for private health insurance due to enhanced marketplace subsidies under the IRA, as well as a temporary special enrollment period for qualified individuals losing Medicaid coverage, contribute toward a record high insured share of the population of 93.1%. In 2024, despite a projected sharp decline of 11.2% in Medicaid enrollment, the insured share of the population is expected to only fall 0.4 percentage point to 92.7%. The insured share of the population is influenced in part by overlapping coverage from alternative sources for people who no longer qualify for Medicaid coverage, as well as by significant gains in private health insurance from enrollment in marketplace plans. The insured share of the population slightly slows to 91.3% by 2026, reflecting a 1.0% decline in average private health insurance growth over 25 through 26 as the enhanced marketplace subsidies expire. Next slide. The next three slides highlight our projections by major payer. Before we start reviewing the key takeaways, I want to explain how these slides are organized. Average annual enrollment growth is displayed in the solid blue bar, per beneficiary spending growth in the striped bar, and spending growth in the black solid line. I also want to point out that the growth rates are calculated from unrounded data. Therefore, numbers might not add to totals because of rounding. This slide will focus on Medicare trends. In 2023, Medicare expenditures are expected to have grown 8.4%, in part due to continued increases in Medicare Advantage enrollment and faster projected Medicare hospital spending. In 2024, Medicare spending growth is projected to decelerate to 6.1%, reflecting slower growth in Medicare Advantage capitation rates and slower projected per enrollee growth in physician spending. The 2025 through 26 period is expected to have average Medicare spending growth of 7.1%. In 2026, Medicare retail prescription drug spending rises as the IRA's drug price negotiations become applicable. During the initial years of the negotiation, affected drugs are expected to have higher rebates that are shifted to the point of sale. A key effect of this outcome is reduced Medicare beneficiary out-of-pocket costs, along with increased federal spending on prescription drugs. For the remainder of the projection period, Medicare spending growth is expected to average 7.6%. Faster spending growth is expected across most sectors, including hospital, physician and clinical services, and home health, that is particularly offset by a slowdown in retail prescription drug spending from the IRA's drug price negotiation and the linking of price increases to the consumer price index. Next slide. This slide focuses on Medicaid trends. 2023 serves as a bridge between a 2021 and 22 Medicaid enrollment surge and the impact of the expiration of the continuous enrollment requirement that flows through 2023 and 24. In 2023, Medicaid spending growth is projected to have slowed to 5.7%. Medicaid enrollment is projected to have reached 91.2 million on an average monthly enrollment basis. This historic high reflects new enrollees as the continuous enrollment requirement resulted in increased coverage. Enrollment growth decelerated from 7.2% in 2022 to 0.5% in 2023. After the continuous enrollment requirement ended, the phase down of the temporary 6.2 percentage point FMAP increase, which expired in 2023, also slowed Medicaid spending. In 2024, as state redeterminations of eligibility continue, Medicaid enrollment is projected to decline by 10.2 million or 11.2%. This significant reduction in the number of people enrolled is expected to result in a decline in Medicaid spending of 2.2%. On a per enrollee basis, the Medicaid spending growth rate is projected to climb to 10.2% in 2024 from 5.2% in 2023, its highest increase since 1991, and to reflect the rapid loss of many enrollees who tended to be younger and healthier and thus less expensive. Next slide. Private health insurance. In 2023, largely reflecting increased growth in the use of healthcare services and goods, on a per enrollee basis, private health insurance spending is expected to have grown 8.0%. Also in 2023, private health insurance enrollment is expected to have grown more rapidly from 1.5% in 2022 to 2.9% in 2023, an acceleration that reflects the enrollment of an additional 3.2 million people in direct purchase plans, coinciding with the temporary special enrollment period and the IRA's extension of enhanced marketplace subsidies through 2025. In 2024, the spending growth rate for private health insurance is projected to remain high at 8.1%. This expected rate reflects gains of 4.6 million more enrollees to direct purchase plans. Over the course of 2025 through 26, average spending growth for private health insurance is expected to slow to 3.8%. In 2026, when the IRA's extension of enhanced marketplace subsidies expires, an enrollment decline of 7.3 million or 19.2% is expected in direct purchase plans. For the latter years of the projection period, 2027 through 32, spending growth for private health insurance is expected to average 4.8%, which is below that of Medicare and Medicaid spending, driven primarily by comparatively slower pace of enrollment growth. Next, Mr. Madison will continue the presentation, starting with the NAG's distribution by type of sponsor. Next slide.
Thank you, Dr. Fiore. Hi, I'm Andrew Madison. I'm an actuary within the CMS Office of the Actuary. And I'm going to give an overview of sponsor, some major sector trends, and key provisions of the IRA, and recap some of the major findings of our study. So we're going to shift gears here and talk a little bit about our A&G projections of distribution by sponsor. And A&G accounting by sponsor is a little bit different than the pay review Dr. Fiore had just presented. It analyzes A&G with a focus on source of financing, meaning it redistributes cash flows such as premium contributions, subsidies, directed taxes, and benefit outlays back to their source. So I also want to note that before stepping into the data here a little bit, that the slide figures are rounded, and some of the totals that I discuss here are calculated from their unrounded totals and may not match exactly if you were to add figures from the chart up. So stepping into the data here a little bit, in 2019, we estimated the government share of A&G, that is the combination of federal government and state and local financing, to have represented 46% of healthcare financing. During 2020, it reached an estimated share of 51%, which is an unprecedented high. And this is mostly driven by temporary PHE policies such as the COVID Provider Relief Fund, Paycheck Protection Program, and some additional public health funding. And as you can see in the chart, federal share of A&G financing jumped from 29% in 2019 to 37% in 2020. Within our forecast period, we project the share to fall back to roughly its pre-pandemic level in 2019 and 2024. So by 2024, we project the government share of A&G financing to come back down to 46% approximately. I want to note that in addition to those temporary PHE funding policies, contributing this downward pressure on the share of financing is an expiration of the Medicaid continuous enrollment provisions under FCRA that Jacqueline had previously mentioned. Stepping forward into the projection period, from 2024 onward, we project the government share of A&G financing to again begin to increase, and it's projected to grow from 46% in 2024 and the projection period 49% approximately. I want to note that much of this increase is accounted for by a growing federal share of Medicare financing as baby boomers continue to age into the program through 2029. Next slide, please. So on this slide, I'm going to give a brief overview of our hospital growth trends for the projection period. And in the National Health Expenditure accounts, hospital care includes revenue received for all services provided in hospitals to patients, and this includes both inpatient and outpatient care, along with some other services billed by hospitals, such as hospital-based home care and nursing home care. For 2023, stepping in the data here, for 2023, we estimate growth in hospital services to have accelerated to 10.1%, and this is up from 2.2% in 2022, and to have reached roughly $1.5 trillion. And this estimated growth trend is derived from a preliminary analysis of the March Census QSS survey data. And we also analyzed the BLS hospital PPI data for the same period and determined the acceleration to have been primarily driven by utilization of services and not healthcare price growth. Stepping forward into 2024, we project hospital spending growth to slow to 4.6%. And this is reflected with a broad deceleration across most healthcare payers in our modeling. Most notably, Medicaid spending is projected to decline by 5.7% in 2024. And this decline is primarily driven by the enrollment patterns that Dr. Fiore had previously mentioned. Stepping forward into the 25 to 2026 period, we project hospital spending growth to remain relatively stable at the aggregate level and to have an average of 4.7%. And underlying this relatively stable growth are disparate public and private payer spending growth trends, and these were driven by the enrollment patterns that Dr. Fiore had walked through earlier, namely the Medicaid continuous enrollment provision expiring, as well as the enhanced marketplace subsidies expiring in 2026. For 2027 to 2032, the final 6 years of projection period, hospital spending growth is projected to average 5.6% a year, with Medicare being the fastest of the payers at 7.6% on average. And this growth differential between the total hospital growth and Medicare is generally driven by enrollment, largely as the baby boomers age into the program through 2029. And overall, for the 10-year forecast period, 2023 to 2032, we project an average nominal growth rate of 5.7% for hospital services. And this is similar to overall projected PHE spending growth trend that we have in our estimates. Next slide, please. On this slide, I'm going to give an overview of physician and clinical service spending growth. Within the National Health Expenditure accounts, physician and clinical services include services rendered in doctors' offices, so doctors of medicine, MDs, and doctors of osteopathy, DO, as well as outpatient care centers and a portion of medical and diagnostic lab service revenue as well. So stepping into the data here, for 2023, we estimate growth in physician and clinical services to accelerate to 8.4%. From 2.7% in the prior year, and to have reached a spending level of approximately $959 billion. And similar to hospital, this acceleration in growth was estimated from a preliminary analysis of the census's March QSS survey release. And after an analysis of the BLS physician PPI data, we determined the acceleration is primarily driven by utilization of services and not healthcare prices, which you can see in the chart. I think we have price growth of 0.5% both in 2022 and in 2023. Stepping forward into 2024, we project physician and clinical service growth to slow to 4.9%. And this again is reflected broadly across most payers. And the deceleration is associated largely with declines in Medicaid enrollment, as well as slower spending growth in the Medicare program associated with Medicare Advantage enrollees. Stepping forward again, for 2025 to 2026, we project spending growth for physician and clinical services to remain relatively stable and average 4.8%. And similar to hospital, underlying the stable aggregate growth are disparate private and public payer growth projection trends. And these growth trends diverge primarily due to the enrollment patterns previously mentioned on the payer growth slides. And for the final 6 years of the projection period, for 2027 to 2032, we project nominal spending growth to average 5.5% in aggregate across physician and clinical services, with Medicare expected to be the fastest growing payer at 7.9%. And again, this differential in growth is largely driven by enrollment trends as the baby boomers age into the Medicare program through 2029. Next slide, please. On this slide, I'm going to give an overview of prescription drug spending growth. But first, I want to give a little bit of a definition of this so it's pretty clear what we're talking about. Prescription drug spending in the NHE includes retail sales of products sold by a variety of entities, and these include pharmacies, grocery stores, mail order vendors, and other entities that sell directly to patients who have a prescription for a drug. And notably, it excludes over-the-counter drugs, so that's captured elsewhere within the NHE. And as Dr. Fiore alluded to earlier, the IRA is projected to impact prescription drugs quite a bit over the projection period. Those impacts are better visualized by plotting spending growth trends by payer. The chart here is at an aggregate level, so some of those effects aren't really easy to see here. We're going to dive into those a little bit on the next slide. So stepping into the data here, for 2023, we estimate prescription drug spending growth to have decelerated to 7.0%. And this is down from 8.4% in the prior year, and for prescription drug spending to have reached $434 billion in 2023. And I want to note that this estimated spending growth was informed in part by an analysis of the IQVIA 2024 Global Outlook, and I think we cite this in our paper. Spending growth in 2023 also reflects both decelerating Medicaid spending growth as well as driven by the PHE disenrollments previously mentioned, as well as increasing PHI spending growth due primarily to recently approved drugs used to treat diabetes and obesity. Stepping forward, we project generally slowing growth across most payers, including negative spending growth in the Medicare program due to disenrollments. Stepping forward again during 2025 into 2026, we project spending growth again to slow somewhat and to average an annual rate of 5.5%. And I wanted to note that in 2025, growth in the Medicare program is projected to slow as the program incurs savings from manufacturer discounts on the low-income population under the IRA. The IRA has multiple provisions going on in this time period, and I think we'll go into those more specifically on the next slide because they're easier to visualize. For the final 6 years of the projection period, for 2027 to 2032, we project prescription drug spending growth to average 5.9%. And this is a mix of a variety of factors, and although subject to considerable uncertainty, we expect the introduction of certain new high-cost specialty drugs to push up growth across most payers. However, conversely, we project slower Medicare spending growth spending due to some key IRA provisions outlined on the following slide. Next slide, please. So on this slide, we're going to walk through some key IRA provisions and their influence on prescription drug spending growth. I think this slide is pretty interesting, actually. It's got a lot of action going on. The IRA is a complex piece of legislation, and it includes a significant restructuring of the Part D benefit. And this is expected to reduce beneficiary cost sharing. It also includes various provisions which affect the pricing of retail prescription drugs in interesting ways, I think, that are paid for by the Medicare program. So this slide presents these trends by payer, which I think is a lot easier to illustrate what is going on with. So stepping into the slide here, for 2024, we see an acceleration in Medicare spending on prescription drugs to 13.3%, and this is up from 8.9% in the prior year. And this comes largely as a result of the elimination of the Medicare Part D program's 5% coinsurance on catastrophic coverage. And as we step forward another year into 2025, we see Medicare program spending slowing quite a bit to 2.6%. And this comes as we see the manufacturer discount for the low-income population taking effect under the IRA. And I also wanted to note that offsetting some of those discounts are a $2,000 cap on out-of-pocket spending for Part D beneficiaries being introduced in this year. And then stepping forward into 2026, drug price negotiations become applicable under the IRA. And during the initial years of this price negotiation, we have a projection assumption that the affected drugs are going to have higher rebates, and these rebates are going to be shifted to the point of sale. And the effect of this is an acceleration in Medicare program spending growth in that year, up to 12.0%. As you can see, is quite a bit higher than the prior year. The effect of this also tends to lower cost sharing associated with these drugs for beneficiaries as well. So it's not all an increase in price. For 2027 forward, we anticipate additional drugs will be subject to price negotiation under the IRA, and there'll be continued effects of CPI linkage into drug pricing flowing through into program spending under Medicare. And then I wanted to note that in 2028, in our key provision of the IRA, starts to apply drug price negotiation to drugs provided for under the Part B program. Spending for these drugs is generally captured in physician and hospital under the NHE, and therefore those trends are not going to be captured in the slide. Next slide, please. So on this slide, I'm going to recap some of our major findings that Dr. Fiore alluded to earlier. Over the projection period, which is 2023 to 2032, we project average NHE growth of 5.6%, and this is expected to outpace average GDP growth of 4.3% for the period, and to result in an increasing health share GDP from 17.3% in 2022 to 19.7% in 2032. In 2023, we project there to have been a very unprecedented high level of insurance coverage in the United States of 93.1%, and for NHE to have grown 7.5%, which is a bit faster than GDP of 6.1% in that year. Moving forward, 2024 to 2026, we see the effect of various enrollment shifts occurring generally as a result of temporary public health emergency policies and legislation expiring. And over the projection period, we expect the insured share of the population to fall back to levels more consistent with the history and to a level of approximately 90.7% by 2032. Dr. Fiore had alluded to many key provisions of the IRA in our initial slides. We expect these to impact the spending on prescription drugs in pretty material ways. And these ways are mostly visualized through our payer growth slides, as we saw earlier. In Medicare, initially, we expect upward pressure on the program spending because of the IRA's Part D benefit restructuring. And thereafter, we expect downward pressure on the program from manufacturer discounts for the low-income population, additional drugs subject to price negotiation, and the linkage of CPI to drug prices. And then similarly, we have an effect of the IRA, which is lower out-of-pocket spending for Medicare Part D beneficiaries, which reflects many different parts of the Part D benefit restructuring, including the elimination of the 5% coinsurance for catastrophic coverage in 2024, and implementation of a $2,000 cap on out-of-pocket spending for Part D drugs in 2025, and the applicability of drug price negotiations. And then overall, as we move forward into the later parts of the projection period, we expect traditional factors to, again, primarily drive healthcare spending growth and healthcare price inflation and growth in the use of healthcare services to contribute to healthcare spending of the economy that's growing over time and faster than GDP. And with that, I'm happy to help take questions and hand the microphone back to whoever wants to take it.
Thank you. Thank you both to Jacqueline and Andrew for the presentations, and also really to your co-authors and the entire office. There's a lot of interesting, important information, and there's a tremendous amount of work behind it, and I'm aware of that, and I really deeply appreciate it. Before we go to questions, just a reminder that the article is under embargo until 4 p.m. today. So we do have time for questions. If you have a question, I'd ask that you use the raise hand feature in Zoom. I'll do my best to keep track of hands that go up. When I call on you, please do state your name and the organization that you represent before you ask your question. So we are open for questions now. I do not see any hands yet. Let me just make sure here I'm not missing anything. While we wait, maybe I have a quick question. There's a good bit in the paper on the effect of the IRA on Medicare and consumer drug spending, particularly with respect to the drug price negotiation aspect of that, since so much is unknown at this point. Can you talk at all about how you quantified the effects, particularly again of the drug price negotiation aspect of that? You mentioned IQVIA, but I don't know if there are other methods or techniques or sources like CBO, or I'm just curious about that.
I think for our purposes, we work very closely with our colleagues who produce estimates and impacts on the Medicare program and in general for the Medicare trustees report. And there is a lot of analysis that goes into these estimates, and it's very complex. There are a number of intertwining impacts that kind of cross each other as you work through the various provisions and things. But as you mentioned, like the whole office contributed to this, even people who aren't necessarily on the National Health Projections, National Health Expenditure Projections team that again, study the data at very fine levels of detail and work through our best technical estimates that we can derive as an office that then flow into the trustees report and our work presented here.
Thank you. I'm not seeing any questions. I want to make sure I'm not missing anything. No hands, no questions. This might be a first. Give folks a few more seconds.
I'll interpret this as as a reflection of the comprehensive nature of the slides.
Yes. Well, I don't want to cut things off early if folks have questions, but I don't see any. So just making sure. Well, with that, I don't know, Sue, if you want to say another word about
Don, somebody's
yeah.
having trouble raising their hand.
Okay.
So
Do they want to
maybe
put it?
folks could just turn on their mics and ask questions.
Yeah, that would be great. Or put it in the chat, either one.
Hi, can y'all hear me?
Yes.
Hi, my name's Rebecca Pfeiffer. I'm with Healthcare Dive. Sorry, I'm having some issues
That's
with
great.
the raise hand functionality. I think it's on my end, but I would just love if y'all could talk a little bit about the factors that drove such high hospital spending growth last year. You mentioned obviously increased utilization, but is that due based on your analysis to recovering demand after COVID, or what else do you think sort of went into that? Thank you.
So there's a number of factors that go into that. We don't have disaggregated data at the NHU level to fully analyze the trend. And if you look into our study, private health insurance had the most rapidly accelerating growth in the hospital sector. But I think we largely attribute it to returning, I guess, practice patterns post PHE. So it's somewhat of a base effect. And then in addition to that, we had very strong financial returns in the hospital sector, contributing to that in terms of their investments during the year due to the stock market.
One thing that I would briefly add is we also rely on the quarterly services survey. And when we examine those data in 2022, the very first quarter of 2022 calendar year, spending was really quite low. And I think we concluded as a group that just generally affects sort of the these lingering effects of the pandemic on the spending patterns that we see. Spending picked up as we moved through 2022 and then just continued into 2023. So those factors all kind of conspired to result in this somewhat sharp acceleration in growth.
And I'll add one more final comment. Speaking towards hospital utilization being a driver, we also have a reference at the end of the article towards Becker's hospital review. So if you want more information there, that's a good note to look into.
Thank you.
Thank you.
Other questions? I don't see anything in the chat. If you do have a question and you're having trouble with the raise hand feature, feel free to come off mute and just ask. Well, if there are no other questions, Sue, do you have anything else that you would want to add?
Thank you, and thanks to everyone. And just a quick reminder that if you haven't contacted me and want an advance copy of the study, my email is sducat@projecthope.org, which is also posted in the chat, and I can send it to you.
Thank you, Sue. So, if no other questions, I do want to thank you for being here today, and particularly to the presenters and to the entire team from the Office of the Actuary. Thanks again for all the work. Really glad you all were able to join us today. So, with that, we are adjourned.
Thank you, Don.
Thank
Thank
you.
you.
Thank you.